So today, really, the course objectives here are to review the pathophysiology of dry eye disease and to really understand the multiple risk factors and the entry points into the vicious cycle. We'll also be talking about the dynamic therapeutic strategy. So what is it and how to create it, and how to implement it into a patient case. And then at the end of the presentation, we'll wrap up with a case example using a dynamic therapeutic strategy. I have no financial disclosures. All right, so this is a great guideline for how to approach the treatment of dry eye. Of course, we have to ask the right questions. So in your clinic, you might implement a validated questionnaire, a symptom questionnaire, or you might simply just implement this into your intake questions. We have to assess the modifiable and the non-modifiable risk factors. Does the patient have a history of soft contact lens wear? Has the patient had a history of ocular surgery? And then you want to determine which diagnostic testing will be helpful. So very simply, you can start with your vital dyes and your slit lamp examination with your lissamine green and your fluorescein strips. You can determine if a TL's molarity MMP9 testing will be helpful, meibography images, anterior segment images. And then, of course, you have to identify whether this is mostly an evaporative dry eye disease case, is this mostly aqueous deficient, or is it really a hybrid? And the one important point that came out of the TFOS-2 report back in 2017 was that most cases of dry eye tend to be hybrid, whereas prior we used to think that they are more stringently delineated. And although we do know that recent research shows that 86% of cases of dry eye do have an evaporative component as well. So you definitely want to be assessing for both cases when a patient presents to you with dry eye symptoms. And then, of course, you have to identify the severity. So is this, like you do with any disease process, so is this more a mild case of dry eye with maybe mild meibomian gland dysfunction, mild truncation on the meibography images, or are the meibomian glands completely atrophied? And so that will really serve as a guide as to how to approach the treatment of dry eye disease. This is a simplified version of the vicious cycle. Successful treatment of dry eye really requires a fundamental understanding that it's a multifactorial disease and that it is a chronic disease process with multiple modifiable and non-modifiable risk factors. So if we break this circle down, we can see that on the outer circle right here, these are our risk factors. The inner circle really represents the scientific changes, the pathophysiology of the dry eye disease process. And the inner circle is the vicious cycle of meibomian gland dysfunction, which is thought to have its own vicious cycle, which then plays into the cycle of dry eye disease. So let's talk about meibomian gland dysfunction. So we identify that the patient has decreased quantity and quality or quality of meibum really. And then we want to treat this with either in-office thermal treatment or in-office thermal pulsation treatment and or photobiomodulation, such as intense pulse light or low-level light therapy. Let's say, for example, that we identify the patient has an allergic component. So you might want to implement percutaneous allergy testing in your own office, or you might want to send this patient out for that testing and co-manage with an allergist. Really, you do want to manage the patient's exposures. Maybe the patient might need some systemic allergy medication to help with management as well. For a patient who has a history of soft contact lens wear, you might ask them to reduce their daily wear time or switch them over to a more breathable material. When you identify signs of dry eye, let's take one example of inflammation. So you might identify that there's superficial punctate keratitis on the cornea, a breakdown of the epithelium. So you might want to start immunomodulators for more long-term control, or you might want to start with steroids for more short-term control. So as we discuss this further, really what we're aiming to understand are the multiple entry points, and then we will review how to implement dynamic therapeutic strategies for each. So this diagram is from the pathophysiology section of the TFOS-2 report. And the reason I like it is because it really just very easily illustrates the complexity of all the mechanisms and how they come into play when it comes to dry eye disease. And it also highlights that, of course, it's a multifactorial disease that requires multi-treatments. There's not really one silver bullet that addresses each of these risk factors. So let's review the mechanism. This represents the vicious cycle, obviously, and it starts right at the top here with tear evaporation, which then leads to tear hyperosmolarity or a salty concentration of tears, which can occur then from either, your evaporative or your aqueous deficient dry eye. That then leads to inflammation. So you've got your mitogen activated protein kinases, your pro-inflammatory cytokines, your interleukins, your tumor necrosis factor, and matrix metalloprotease 9, which we all know as MMP9, which is tested with diagnostic testing such as an inflammadry. That then leads to epithelial apoptosis, which then plays into an unstable tear film. You can have Meibomian gland dysfunction, which feeds that unstable tear film, again with a decreased quantity or quality of the meibum, and that just kind of perpetuates the entire cycle. Other entry points into, let's take another example of an entry point, that would be blinking, for example. So when you have a decreased blink rate or you have an increased aperture size, that will increase tear evaporation on the surface, and therefore that would be the entry point at which you would enter the cycle. For a patient who has similarly a history of contact lens wear, a history of ocular surgery, corneal nerve dysregulation, these are all other examples of how you could enter that vicious cycle. Many inputs, many treatments, not just one silver bullet. And really, you can introduce treatment at any one of these controllable or modifiable risk factors, and really at any stage in attempt to break the cycle. But the point really here is that it does take multiple treatments, and you want to layer that treatment in a multifactorial approach. And as we talk about the dynamic therapeutic strategy, we'll talk about how to layer those treatments. And as we're going forwards, I want you to think about when your patient presents to you with dry eye symptoms. And I really want you to think about how you would implement this treatment in a multi-layered approach in your clinic. So let's consider one factor that's changed our lives significantly over the past year and a half that more often than not leads to tear evaporation, and that is wearing a mask. So an ophthalmologist early last year coined this term, this acronym, MADE, mask-associated dry eye. And there was a study that was conducted that I found very interesting. Out of about 203 participants, they found that females with pre-existing dry eye had an onset of symptoms just 3 hours after wearing a mask all day. Now, of course, that will cause tear evaporation on the surface of the eye when you're breathing, when you're talking, that air is propelling up. And me, for one, definitely 3 hours or maybe even sooner of wearing a mask, and I'm starting to feel those symptoms. And it becomes very frustrating throughout the day for me to have those symptoms. And it really does affect my quality of life. And so there is an obvious need, almost a burden on us as eye care providers to help these patients through their symptoms of dry eye. A study that was conducted in Europe asked respondents this question: please tell us if you have felt any of the below emotions as a direct result of your dry eyes in the past 4 months since the start of the COVID-19 crisis. And that was between March of 2020 to September of 2020. Surprisingly, or maybe not very surprisingly, 1/3 of patients reported that they felt stressed or they felt frustrated and exhausted and irritable. These things, these feelings, these emotions that are being elicited by these symptoms are inevitably going to affect one's quality of life and the state of their mental health as they're getting through their day. 4 out of 5 people with dry eye felt that their condition increased the severity of their mental health and quality of life. Factors such as stress, fear, depression, anxiety. And the one that really stuck out to me was unhappiness. People are really being affected psychologically. There's a huge mental health factor and psychological impact of dry eye that we should recognize in our primary care clinics and be addressing. So let's start talking about some of these entry points. So the argument can be made that dry eye disease is an inflammatory condition. And when I treat these patients in my clinic, I am operating under this assumption. So if we think back to our cycle, we know that tear evaporation causes more salt in the tears, which then causes changes in the corneal epithelial cells, right? So specifically by the mitogen activated protein kinases in the epithelial cells and those inflammatory cytokines. That is then going to lead to a breakdown of the glycocalyx, especially the most prolific gel forming mucin, MUC5AC. That's also reduced. There's damage at the level of the conjunctival goblet cells as well. And that leads to epithelial cell apoptosis. nervous. And so when you are identifying the signs of inflammation on the ocular surface, I would encourage you to look kind of externally, kind of from out to in, so to speak. And so you really want to start looking at the eyelids first. And you might notice that the eyelids are hyperemic or even edematous, excuse me, or even that the eyelids are thickened. So there's eyelid tylosis on the eyelid margins. You might notice big kind of blood vessels, almost they look like they're feeding the eyelid margin. That's a sign of inflammation. Eyelid telangiectasias that you might see very commonly in Demodex blepharitis and ocular rosacea, which are both inflammatory conditions. You might see signs of Meibomian gland dysfunction and or blepharitis. That again could be either a mix of staphylococcal or Demodex, or individually both. Conjunctival hyperemia is a landmark sign really of inflammation on the ocular surface. And then of course a breakdown of the corneal epithelium with superficial punctate keratitis as well. I will say here that I love using a Ratten filter to identify little bits and patches of SPK that I might not necessarily see with a cobalt blue filter. So if you have access to a Ratten filter, definitely something to consider implementing when you go back to the office on Monday. You might also perform MMP9 testing in the clinic to help identify signs of inflammation there on the ocular surface as well. In terms of symptoms of inflammation, I think it's kind of all across the board. I definitely would include photophobia, burning, itching, mucoid discharge here as well, however. With Meibomian gland dysfunction, like I mentioned before, it does have its own kind of vicious cycle, which then enters into the vicious cycle of dry eye that was proposed by the TFOS, really characterized here by dropout, obstruction, and inflammation that causes stasis. You're seeing changes in the quantity and the quality of the meibum. Is it more waxy or inspissated like toothpaste? Is it yellow or is it completely white? And that really just contributes to a reduced lipid layer, which then you will see a reduced tear breakup time as measured with your fluorescein strip on the ocular surface. And that's indicating and really pointing towards Meibomian gland dysfunction. Same with identifying blepharitis. You want to look for that reflection, that shiny reflection from the eyelid margin, which indicates that bacterial biofilm presence, and also hyperkeratinization along the eyelid margin as well. When we talk about frictional stress, basically when inflammation occurs due to the increased salts in the tears or the hyperosmolarity, there's a change in the conjunctival cells and in the goblet cells. And specifically, we're talking about the wetting glycocalyx of the epithelial cells. It's reduced because you have a reduced production of the mucins. One change that this can lead to is something called lid wiper epitheliopathy. So you see a picture here on the top right. It's basically characterized by frictional damage along the stratified squamous cells of the conjunctiva. So the lid wiper region is a normal part of the anatomy, and it's located just at the mucocutaneous junction. So you're going to see that staining when you put your lissamine green stain in. And the lid wiper region helps to kind of spread the tears on the surface on the blink. And lid wiper epitheliopathy occurs when there's any staining really further than that staining of the mucocutaneous junction or that line of marks. And there was actually a study that reported up to 80% of soft contact lens wearers really have signs of lid wiper epitheliopathy. And I would encourage you to actually invert the lids once you've let the lissamine green dye settle for a few seconds, because it's really very obvious when it is present on the superior lid margin, as opposed to a little bit more difficult to identify on the inferior lid margin. So you're seeing those frictional forces on the ocular surface when you are identifying the lid wiper epitheliopathy. And I would essentially encourage you to think about the dynamics, the blink forces that are happening on the front of the eye. When you have a thinned tear film, then the epithelial cells are starting to become damaged as you've got that frictional force that's occurring with every blink on the ocular surface. Lid parallel conjunctival folds, you can see those really on the inferior temporal margin there, are a sign of frictional stress on the ocular surface, as well as SLK, superior limbic keratoconjunctivitis. And so really instilling your stain, make sure that you're, in addition to everting the lid, have the patient actually lift the eyelid and have the patient look down so that you can identify some of these signs. That can be helpful there. In this video, we can really identify, I love this video because it really helps us identify multiple factors when we are assessing for the blink mechanism and also tear film instability. So at the beginning here, we can appreciate a patchy tear film inferiorly on the inferior third of the cornea. So I'm going to help you identify that there. Then you can see this line about 2/3 of the way down the cornea. And you'll see that when I play the video again, I want you to look at the blink and identify whether that superior eyelid is touching that inferior eyelid on the blink. When it doesn't do that, we call that an incomplete blink. And what will happen, you'll see here, is that you get this tide line. And that will essentially represent that superior eyelid as it comes down on the downward action of the blink and kind of where it stops to help you identify that incomplete blink mechanism. And that essentially leaves that inferior portion of the cornea naked, which is then where you see that patchy tear film and even some spots of SPK there as well. So I think that's a really, really nice illustration of that mechanism there. And in this one, we really can start off appreciating a very patchy tear film, right? So let me pause that right here. You can see these streaks, and that is helping us identify that early tear breakup time. Tear breakup times can be a little bit fickle in my experience. And even in the same sitting, you might ask the patient to blink, and they might have an immediate tear breakup time. And then on the second and third blink, you might see maybe 2-3 seconds out. And this video is a very nice illustration of that. So that I would call that an immediate blink. And then on that second blink, you might argue that's a few seconds in. So again, definitely the idea here is that this tear film is very unstable. So when you have an incomplete blink, you're seeing an unstable tear film, you really should be looking for those signs and symptoms of Meibomian gland dysfunction as it relates to the tear film instability there. Now, when we talk about ocular surgery, I really love this picture here because using the Ratten filter and the fluorescein dye, you can really identify those Lasik flaps there. Again, this patient, this is a photo, not a video, but you can see here that this patient does have a tide line of the tears. There's a patchy tear film that's surrounding that inferior aspect of the flap. Studies show that dry eye post-Lasik is really the most common complication after Lasik, and that usually resolves in 50% of patients at the 1-year mark. And so really with your patients who have had Lasik, the one thing I would say is that you want to monitor these patients even a year out and beyond. So that you can really correctly identify those signs of dry eye. And don't forget about perioperative drops either in cataract and refractive surgery patients. The toxic preservatives and the compounds, the active compounds themselves, can create a pro-toxic, kind of very pro-inflammatory environment on the ocular surface. And benzalkonium chloride, as we all know here, is the most prolifically used topical preservative in eye drops in the ophthalmological world. And benzalkonium chloride has been shown to be pretty toxic to the epithelial cells of the conjunctiva, the epithelium, and multiple other structures on the front of the eye. And sometimes what I find with my patients is that they've come away from surgery and they're about 3 months out and they come to me for their follow-up and they're still using some of their eye drops if they haven't run out already. And so really educating the patients that, they only need them for a certain amount of time so as to not expose that already compromised ocular surface to even further toxic preservatives can really help just with a little bit of patient education there. And when we talk a little bit more about Lasik and dry eye, we know that there's a link between Lasik and dry eye. This might be due to a disruption of the corneal nerves, which therefore then decreases the corneal sensitivity and affects the blink rate by reducing it. When you have a reduced blink rate, remember that you need those muscles of rheolin on the superior and the inferior eyelid to really touch in order to release that meibum from the meibomian glands. If you have a reduced blink rate or if you have an incomplete blink, that's not going to happen, and therefore will lead to meibomian gland dysfunction, which then leads into an unstable tear film and propagates that cycle. So you might have a link in that regard, or you might have a link in relation to the way that the Lasik is performed with the use of the suction of the conjunctiva, which can cause a disorganization of the conjunctival epithelial cells and the goblet cells, and even damage to those cells. And so a clinical pearl here is for Lasik patients, just as you would with pre-cataract patients, you really want to be treating that ocular surface before sending those patients in for their Lasik evaluations. And contact lens wear. So contact lens wear, the TFOS DUES 2 report cited that just 2 years after wearing soft contact lenses, you can start to see signs of meibomian gland dysfunction. And so you really want to educate these patients here. And that's going to be by way of the reduced lipid layer and the reduced wettability on the ocular surface. Neurological dysfunction accounts for the disconnect between the signs and the symptoms. We all have these patients in our clinic who have signs but no symptoms, or symptoms without signs. And these are the challenging cases to manage, right? I mean, when things don't add up, and it's difficult to convince the patient, especially in those neurotrophic keratitis patients. So we know that the uncapsulated nerve endings of the corneal nerves are located in the epithelium, and the majority of the corneal nerves enter into that Bowman's capsule through the anterior stroma, and that's called the subepithelial plexus. Most of the sensory nerve fibers in the epithelium are what we call polymodal nociceptors, right? So it means that they react to a variety of stimuli, and that includes mechanical energy, hot, cold, temperature changes, changes in tear osmolarity, noxious chemical stimuli as well. So these can be exogenous, meaning that they're external stimuli, or they can be endogenous, meaning it's coming from within the corneal epithelium itself. And in a very simplified explanation, what's happening is that these nerve terminals are detecting and reacting to these multiple stimuli and sending that information over to the trigeminal sensory complex, which is then projected up to the thalamus and up to the somatosensory cortex, and then we feel the stimuli. Again, a very simplified version of that pathway, which deserves a lot more attention when it comes to dry eye. So this innovation changes with input into the vicious cycle. For example, through surgery, when we sever the corneal nerves, and when the system breaks down, we start to see a dysregulation in the nerves, and therefore corneal degenerative nerve disease, and therefore signs and symptoms won't add up. So in corneal neuropathic pain, we see patients who suffer from allodynia, or a large response to a very small stimulus, such as wind. And then in neurotrophic keratitis, patients can have very little symptoms, but they have signs of significant corneal epithelial disease. So these are the patients who've had maybe a history of multiple surgeries. They've had infections on their cornea with zoster simplex, and maybe they've even had long-term exposure to toxic preservatives. So these glaucoma patients might present in a case like this. So you'll see these significant signs of epithelial disease, 3+++ coalesced SBK on the surface, and the patient might, at the very most, complain that they have intermittently blurry vision, but they really have no symptoms. And so that's a classic neurotrophic keratitis case there, very difficult to manage. When we talk about aqueous deficient dry eye, that is defined as a reduced tear meniscus height or reduced tear volume. Most often it's due to reduced production of aqueous coming from the lacrimal gland. Risk factors for developing a reduced aqueous output are corneal nerve damage, use of anesthesia, contact lens wear, systemic drugs. So those are antihistamines or antidepressants, diuretics, beta blockers, and then infiltrative disease of the lacrimal gland, such as Sjogren's syndrome. So when you have a reduced output from the lacrimal gland, you then therefore enter that cycle of vicious dry eye, starting at the top with tear evaporation, and then increasing the salt in the tears, and so forth. And so very interestingly, there's a recent study that was published a couple months ago, and it showed that there was a larger decrease in corneal nerve density in aqueous deficient dry eye patients as opposed to evaporative. And this was thought to be due to inflammation in aqueous deficient dry eye patients. I thought it was very interesting. So now that we've talked a little bit about the entry points into the vicious cycle, what I would like to do now is review how to implement a dynamic therapeutic strategy. What do I mean by that? I mean, how do I figure out how to treat these patients? And so the TFOS DUES 2 Management and Therapy Committee proposed a treatment algorithm. And I'd like to introduce this, and I'd like to really talk about how to use this algorithm when you are implementing your own dry eye protocols. It's really intended to be used as a guideline, okay? And it's not really a flow chart. So it's a stepwise approach in the sense that it outlines steps 1 through 4, but it's really not meant to be used as a flow chart where if step 1 doesn't work, you move on to step 2 and so forth. I would like to highlight, I think step 1 really deserves a lot of attention because it's going to serve as a foundation to almost a pyramid, is the way that I like to think about it. So when I think about treating dry eye, it's almost like a pyramid rather than a flowchart. So we use this algorithm really as a organizational tool, and we have to be ready to pivot based on severity. So the algorithm suggests that if step 1 doesn't help resolve the symptoms, then we can try XYZ in step 2. Now, if you have a very severe dry eye patient, maybe you have a speed score of off the charts, 28 out of 28, and the patient is very uncomfortable, they have signs of SPK, they have filamentary keratitis, where you might reach for a step 3 treatment rather than a step 2 treatment, just to kind of get things under control and then backtrack to step 2. So you really want to be ready to be pivoting based on the severity. And then again, it's not really a flowchart, it's a pyramid. So when we talk about step 1, we're talking about educating the patient regarding their condition. We're talking about modifying behavioral, dietary, and environmental risk factors. Are they using ceiling fans? Are they taking in a diet that's rich in re-esterified omega-3 fatty acids? What sorts of sources is that coming from? Is that marine-based? Is it flax seeds, chia seeds? That's very important. And then also looking at their environment and their behaviors. And so these treatments in the step 1, they're going to stay throughout the entire treatment. It's a chronic disease process. So you're really going to need to implement that step 1 in order to create a long-term management plan. So let's talk a little bit about environment. So let's talk about humidity, for example. So low humidity increases the blink rate to reduce evaporation rate, and that's a compensatory mechanism. Again, recall that that the key to initiating the vicious cycle is that tear evaporation, which cannot occur unless that you've got some level of evaporative stress that's occurring on the surface of the eye. So a humidifier can really help here, as well as reducing ceiling fan use, especially at nighttime, and also when the patient is in the car, facing those AC vents away from the patient's face. I just have them put them on their feet instead. You want to assess the blink mechanism and also how the eyelids close. And I want to talk about the Korb-Blackie light test here. So I assess for this in every single patient. What I ask the patient to do is gently close their eyes, and I hold a pen light to the superior eyelid. I don't want to create any pressure with that pen light. I just want to hold it there and look for any streams of light that might be coming in between the eyelids, showing me that there is an incomplete lid seal. That's different from lagophthalmos. Lagophthalmos is when the eyelids are not touching. In an incomplete lid seal, the eyelids are touching, because as we know, when the eyelids close, they don't close appositionally, right? The superior eyelid kind of goes over the inferior eyelid. And when there is an incomplete lid seal, there's a little gap. So if light can come in, light can come out, air can definitely go in. So these patients might complain of symptoms that are worse in the morning. So using a humidifier at nighttime and cutting those ceiling fans can certainly help with that. Cosmetics is an interesting one because there's really an overlap in multiple categories here. Eyelash extensions, this is a very popular one. It's becoming a multi-million or billion-dollar industry, especially with the use of masks. And really there is an ideal length for eyelashes, and that is 1/3 of the length of the eyelid margin. Anything more than that, which of course eyelash extensions, that's the whole point of them, going to create a wind tunnel effect, which then creates evaporative stress on the ocular surface. And of course, ingredients in cosmetics can also be harmful. You'll be very surprised once you start looking into this to understand how many eye makeup products actually contain benzalkonium chloride. So I sometimes ask patients to bring in their cosmetics, that's including eye creams and anything they're using around their red nexa at nighttime, so that we can look at those ingredients together. And when we talk about digital device use, we all know here that we're looking at the blink rate. And I also want you to think about the position of the patient's screens. So when you have a larger aperture size, so when you're having to look up at a screen, not only are you going to have significant neck and shoulder pain, but you actually have an increased tear evaporation because that surface area is much larger. So have the patient either position their screens right in front of them or slightly downward, and that's also ergonomically a little bit more friendly on the neck and the back as well. And then of course talk about the 20-20-20 rule. When I ask patients to implement this rule, I also add a fourth 20, and that is to blink. And I talk to them about thinking about that Meibomian being released when they're blinking, and that seems to help patients. There are apps that can be helpful for this. I have patients set timers on their phones or put little Post-its. People are still using Post-its these days, right on their screen to help them and prompt them throughout the day. When we're talking about treating inflammation as an entry point, you really want to be looking for signs of inflammation that we talked about, and then implement treatment right away. So for Meibomian gland dysfunction, you might start with at-home treatment, like a microwavable heat mask. When you're talking about in-office treatment, you might do thermal heating treatments and then a manual evacuation of the Meibomian, or you might use a device that does both, the thermal piece and the pulsation piece. Photobiomodulation with intense pulse light. So we have a great mode of photobiomodulation that's now FDA approved. That's really helpful. The IPL. Steroid topical treatments with eye drops and ointments can be helpful. Oral antibiotics. We have a lot of research on the efficacy of oral doxycycline and azithromycin for the treatment of Meibomian gland dysfunction, as well as dietary supplements. And hopefully you are recommending high-dosed, re-esterified triglyceride form of omega-3, which is really a high-quality form of omega-3 fatty acid. When you're identifying signs of blepharitis, you can certainly implement surfactant cleansers, tea tree oil-based cleansers at home, and then those microblepharoexfoliation exfoliation treatments in the clinic. With signs of inflammation in the epithelial cells on the conjunctiva and in the cornea, you're really reaching for those anti-inflammatory steroids and the immunomodulators, such as cyclosporin, 0.05, 0.09%, as well as lifitegrast. And then we've got biologics, huge area of research really developing when it comes to the treatment of dry eye, corneal neuropathic pain, neurotrophic keratitis. So dehydrated and cryopreserved amniotic membranes can be helpful here. Biologic eye drops, these are manufactured eye drops that can be very helpful, as well as autologous serum and platelet-rich plasma eye drops there as well. When we talk about treating frictional stress, then we really want to think about what's happening at the level of the mucin production and the glycocalyx. And so an immunomodulator, we know increases goblet cell density, cyclosporin, that can be very helpful. You want that anti-inflammatory action happening on the front of the eye, as well as Botox can actually be very helpful here with reducing the frictional stress, especially in cases with the superior limbic keratoconjunctivitis and filamentary keratitis as well. When we think about frictional stress, we think about that thinned tear film on the ocular surface and how that creates almost, those shearing forces on the ocular surface. Tear substitutes can be very helpful, and using the right tear substitute for the type of dry eye that the patient has can also be very helpful. So sodium hyaluronate is a great way to start. It's a high molecular weight molecule, and it acts as a humectant to help retain those tears on the surface of the eye, as well as a lubricant and a hypoosmotic here as well. And this report I really liked because it demonstrated that dry eye symptoms and the tear breakup time improved just 6 hours after instilling 1 drop of hyaluronate on the surface of the eye. And in the United States and in Canada, we have some great over-the-counter sodium hyaluronate artificial tear substitute options. And so that's a great way when you're thinking about implementing those step 1 treatments. So I wish I could poll you guys here, but I'd like you to think about what your answer would be. So the question is, what percentage of patients are underdiagnosed with dry eye prior to cataract surgery? And the answer here, hopefully everybody got it right, is 20 to 25%. So 1 out of 4 patients is underdiagnosed with dry eye prior to surgery. That's really big. Dry eye disease and diagnosis is important for determining which IOL will be most suitable, just based on the patient's visual demands, and also the timeline for placing the implant. And we have a growing area of research that shows us that dry eye disease, number 1, is very undiagnosed in patients who are going in for surgery, but also that the presence of dry eye with certain indicators, inflammation, tear osmolarity, in assisting this diagnosis can actually affect the outcome of the surgery. And so often the concern in treating dry eye is the delay, right, of performing the surgery. And so that's something that you can address as a primary care provider. Again, I really like the Ratten filter to help identify those LASIK flaps and those little bits of SPK. That can be very helpful. Make sure that you're looking for that. Sometimes my patients don't remember that they've had LASIK procedure or that they've had cataract surgery. So definitely look for those signs throughout your exam as well. So when we're talking about the algorithm for treating patients who are going in for surgery, there is the asterisk at the American Society of Cataract and Refractive Surgery algorithm that suggests a stepwise approach, with the overarching theme really being that you want to identify and treat early and treat pretty aggressively. And really you want to prime the ocular surface 6 to 8 weeks before sending that patient out for surgery. And so, yes, you want to implement your step one treatments. Like I said, that's always foundational. But perhaps instead of implementing your heat therapy with a microwavable heat mask, you might suggest to the patient that they have thermal pulsation and microblepharoexfoliation done in the clinic to speed up their meibum evacuation. You might reach for those oral antibiotics a lot sooner than you would if the patient wasn't going in for surgery. You might even suggest photobiomodulation, IPL, for Demodex and signs of ocular rosacea. And steroids are very big. When you see signs of SPK, reach for those steroids, low-dose steroids very early to really help gain control of the ocular surface. Again, step one is always foundational. And this is going to be helpful because your role as the primary care optometrist then is to see the patient through the surgery and then monitor their dry eye after the surgery as well. The patient doesn't understand their disease process is ongoing and chronic and it's multifactorial and all those things that we've talked about thus far in the presentation. They're not going to really understand why they need to continue their treatments after surgery. So don't skip step one because the educational piece is key. The FAAO study demonstrated a huge disconnect in what we're doing in our clinics and how we're identifying patients with symptoms of dry eye. So it demonstrated that 60% of patients going in for cataract surgery never even complained of foreign body sensation or any symptoms of dry eye, yet 63% had some sort of corneal staining and a tear bar of less than 5 seconds. So obviously a huge disconnect between those signs and symptoms, and not identifying those signs correctly can actually affect the keratometry and the biometry readings as well. And we know that from a study that was conducted by Alice Epitropoulos and some others, that the readings can be affected by more than half a diopter. And now we're seeing research that those readings might be affected by 1 diopter. That's huge. Imagine that patient going in, spending thousands of dollars on a multifocal IOL implant, and then the goal is off by 1 diopter. So that's going to be a very unhappy patient. I have an article in the Modern Optometry Collaborative Eye publication from October 2020 where I review how the dry eye workup in a pre-surgical patient differs from a non-surgical patient. So if you're interested, you can read more about that. And let's talk a little bit about contact lens wear as well. So we see this every day in our primary optometric clinics. And what I would recommend here is that, we're encouraging the patient to reduce their contact lens wear time and maybe even switch them over to a more breathable, higher decay material, and even consider those daily disposables. So this is a direct quote from the TFOS DUES 2 when it comes to addressing neurological dysfunction. Further research is warranted. So for neurotrophic keratitis, we do have a new drug that's available for our patients, and it is known as Synergimen or Oxybate by Dompé. It's an FDA-approved treatment, and it's a recombinant form of human growth factor that's dosed at 8 weeks. And so that's shown very promising results when it comes to the resolution of neurotrophic keratitis, as well as corneal nerve health and corneal nerve density. For management of corneal neuropathic pain, it's a little bit more complex. Systemic pain management is usually required, diet, exercise changes, diet, for example, that's rich in antioxidants. Psychological evaluation and treatment is definitely very helpful. Acupuncture, seen this in my clinic. Antidepressants such as amitriptyline and neuromodulators such as gabapentin can be helpful here as well. With corneal neuropathic pain, again, a lot more complex and definitely warrants co-management with other specialists such as pain specialists. So really just here highlights the importance that dry eye disease it's very important to co-manage and collaborative management with other specialties as well. So we are nearing the end of the presentation. What I would like to do is wrap up with a case. So this is a 39-year-old female. She comes into me on step 1, step 2 treatments. She's on lid scrubs. She's on at-home heat therapy with a microwavable mask, and she uses lifitegrast eye drops, 1 eye drop twice a day. She's been on this for about 6 months. She's not really seeing a significant improvement. Her speed score is 9 out of 28, and she complains mainly of burning that gets worse as the day goes on. T-bar is 0. You can see that she has a ton of SPK here, very patchy, coalesced in some areas here as well. Her tear osmolarity is 395 and 391. So she has salty tears, and she has a positive MMP9, which is corroborated by that presence of SPK. So she's unhappy, and I want more information. So I run a meibography here, and we can see obvious atrophy of the meibomian glands bilaterally. That's extending from the nasal to about central. We can see some mild dilation as well as truncation of those meibomian glands there as well. So meibomian gland dysfunction obviously is a significant risk factor, is why she's experiencing her symptoms. Her other risk factors include 2-week disposable contact lens wear. She's a high myope, so she wears them for about 12 to 14 hours throughout the day. She has a history of punctal plugs as well, and she's on generic latanoprost. Remember, she's very young. She's 39. She's being monitored for ocular hypertension. She has thin pachymetry, no history of ocular surgery. She has small CDs, and she has a Tmax of 29 in each eye. She's also an engineer, and she works on screens all day. She's been doing this for about 10 years. And when I talk to her about her screens, she says she has a few different screens, and the monitors have been rotated vertically. So sometimes she does have to kind of look up and down the screen. She doesn't smoke, but she is 39, so maybe there are some hormonal changes occurring here as well. I asked her about her environment at work and trying to elicit why these symptoms are worsening throughout the day. She says she doesn't wake up with the symptoms, but they worsen throughout the day. And what I find is that she uses one of these little fans on her desk throughout the day when she's feeling warm. And so you can already identify multiple risk factors when we think about our vicious cycle here. So let's go back to this slide. So she may have some sex steroid hormonal imbalance there. We've seen that she has signs of meibomian gland dysfunction, very obvious. She uses generic latanoprost, which is preserved with benzalkonium chloride. And so we know that that's going to be toxic to the epithelial cells. She is a contact lens wearer. And then she has some factors in her environment, such as her digital device use and that little fan that she uses. And then she has signs of inflammation on the front of the eye through that vicious cycle of meibomian gland dysfunction, and as well as hyperosmolarity, which we measured with tear osmolarity. And then, of course, you've got your signs of inflammation, which is very obvious with that superficial punctate keratitis there. So what treatments did we implement? So I actually like to layer on these treatments all at once for these patients. So she's not really willing to decrease her wear of contact lenses, so we kind of left that alone for a little bit. When you do have to kind of but you actually need to have your patient on board and completely committed to your treatment. So if something is unrealistic to the patient and they're not going to be able to do it, you should try to elicit that through your exam. So to address her meibomian gland dysfunction, we performed an in-office thermal pulsation treatment that was preceded by microblepharoexfoliation exfoliation. I did add a dietary supplement of re-esterified high-dose omega-3 fatty acid as well. I started her on a soft steroid twice a day, loteprednol 0.5% twice a day, and I did have her continue her lifitegrast as well. I stopped the use of plugs. There are some observational studies that show that maybe meibomian gland dysfunction nasally can occur with the use of plugs, and I did refer her out for SLT. She's now had 1 round of SLT. She has achieved a 30% target of her Tmax, so we're happy with that for right now. We've discontinued the use of her latanoprost. I talked to her about her screens, digital device use, her blink rate, kind of her blinking exercises, blinking more intentionally as well. I asked her to stop using that little stand fan that she has on her desk. If she feels warm, put it on her feet. And she might even consider using a humidifier in the office as well. And so she's feeling much better. when you are implementing treatment, you really need to understand the severity of the disease process. Don't be afraid to layer these treatments right at the very first visit. The other thing is that just because the step one treatments that you implemented didn't work because the patient doesn't feel better, doesn't mean that there is actually no therapeutic effect. What it means that we just need to layer, we need to move on to step two, but it doesn't mean that we stop those step one treatments. So for example, if the at-home heat therapy isn't working, move on to in-office thermal pulsation. And I have a very low threshold to moving on pretty quickly for that. So obviously her cornea has improved significantly. It's not perfect. She still has a patchy tear film. What does this mean? Well, we're controlled for now, but this is a chronic disease process, right? So what are some recommendations to help manage a chronic disease process? Well, we want to treat early. We want to manage those expectations. We want to manage those exposures. Keep step one on board. Throw those treatments on early and then back off, right? So we have the Lifitigros, we have the steroids. She's not going to be on steroids forever. We can certainly pull some of those treatments back once she starts to feel an improvement. Maintenance therapies, I always educate my patients. When you have photobiomodulation in the office, when you have thermal pulsation in the office, this is not a one and done deal. This means that we're going to require maintenance therapies, whether that's every 6 months, every 9, every 12 months, and set that expectation early. So when you have that conversation in 6 months, it's not a surprise to the patient. We have some great tools to help us with managing flares. So in the United States, we have loteprednol, 0.25%. That's now FDA approved to manage flares. So I'm very comfortable with reaching for those steroids, and then they do work. And really just educating the patient that their disease process is chronic, like arthritis. You are going to have good days and bad days, and you really want to help control that. And that's when your step one treatments and your education is going to be helpful. So that wraps up the multifactorial approach to dry eye disease. Thank you for bearing with me throughout this talk and for your attention. We've highlighted how to create a dynamic therapeutic strategy based on the risk factors, and I'm really excited to hear about how you implement some of these treatments when you go into your clinic on Monday. And so please feel free to connect with me anytime, and you can either email me at my personal email address, you can reach out to me on social media, and enjoy the rest of the phenomenal speakers. We have an amazing event lined up for you. Thank you so much, and I will see you in the question and answer session shortly.
Hi, Dr. Kataria, welcome. That was such an amazing, amazing overview of dry eye. Really inspiring, you have some really great information, and we have tons of questions. I don't think we'll get through all of them, so I apologize if we didn't get to your question that you asked in the chat. The first thing I think we'll talk about, because this is really hot topic and really got a lot of people going, is how do you talk to people about their eyelashes without offending them?
That's a great question, and is not an easy conversation. And it's definitely taken me a while to understand how I should approach this. And so I will share what my conversation is with the patient. And that is, if a patient really wants to wear eyelash extensions because it makes the person feel good and it's an important part of their appearance, then I support them on that, and I tell them, I say, I will support you on this, but I will educate you on what the downsides are. I always encourage them, I educate them about the allergic reaction that can happen with the compounds in the glue. And for example, that would be the formaldehyde and the latex especially. And so I'll encourage them that the esthetician should be doing a test patch to make sure that you're not having an allergic dermatitis reaction. And then also, how do you take care of them? So maintain them with hydrochloric acid spray, and then also with a little spoolie, a clean one, obviously, and just go right at the base of the lashes so that you're not ripping off the extensions. And make sure that the patients are refilling them every 2 to 3 weeks, because some of these patients will come in and they haven't been redone for 8 weeks, and they're causing matarosis and thickening of the eyelid margin. So that's how I will approach it in a patient who really wants to continue to wear them. And that way the patient's going to come back to me so that I can monitor for any complications.
Oh, that's really great advice there. Kind of sticking with the cosmetic theme here, what about Botox and dry eye? Have you seen it? You know, how do you again talk to patients about that? What are you really doing in that realm? Because obviously a lot of people who are, you know, with eyelash extensions are also getting Botox, and we all want to be pretty and, you know, feel young. So
Absolutely, yes. And so with Botox, the conversation is definitely a little bit different. I do encourage patients to go to somebody who really understands the anatomy around the eyes. And so um, uh, ocular plastics, if you have somebody in your area, reach out to them and have a conversation and say, I have some patients who are interested in this procedure. Can we sit down and have a chat about how that affects the ocular surface? And it can be helpful. There are studies that show, depending on where the Botox is injected, it can actually be helpful in maintaining tears on the ocular surface, for example, if it's nasal. Now, if it's too close to the lacrimal gland region right here, and a lot of times we do get that Botox for our crow's feet, right? So then there can be implications with dry eye, especially when it comes to aqueous output from the lacrimal gland. So we do have to be careful.
Yeah, definitely. I'm going to ask you a hard one. Probably one of my least favorite type of patient to deal with is the neuropathic pain patient. So what advice do you have? How do you approach these patients? Because they're all over and really, they're very difficult to manage.
Yes. Okay. So a great topic for a different lecture, but I definitely will summarize kind of how I approach these patients. Corneal neuropathic pain is often misdiagnosed as dry eye. And a lot of times we are throwing the kitchen sink at these patients. We're doing everything and it feels that nothing is working. The first thing I would do is implement a proparacaine challenge test in the clinic and try to identify, is this peripheral desensitization? Is it some sort of central issue that's happening? Biologics are treatment options that I will reach for very early. So whether that's my amniotic membrane or autologous serum, eye drops, platelet-rich plasma, if you have access to that. And then, of course, you want to co-manage this patient's pain. These patients are in a significant amount of pain. It's affecting their quality of life, their ability to function. And so a neurologist, somebody who can get them on central pain medications, gabapentin, amitriptyline, a mental health evaluation is very important. Changes in their diet, a diet that's rich in antioxidants. And I've actually have some patients who are also receiving acupuncture. So definitely a lot of co-management goes in with these patients.
Oh, really great. Great answer. And then last question, thinking about omega-3s, I feel like there's so many things out there. How do you decide what you're prescribing, dosage of that, and do you really feel that it's helping the patients and a good thing that we should be recommending?
Yes, it's a treatment option that I recommend for patients at step 1. So it's the first thing that I will recommend when it comes to dietary and behavioral modification. So that's step 1 of the TFOS-DUES-2 treatment algorithm. Somewhere between 2,000, 3,000 milligrams is what I will recommend. It's very important for it to be a re-esterified triglyceride form. And so that's going to be more bioavailable. You don't get those fishy burps as compared to the ethyl ester form that you'll find over the counter, like your Walgreens brand. So it's very important to get those patients on, especially pre-surgical patients and Meibomian gland dysfunction.
Yeah, that's great. Really awesome. Thank you so much for joining us for the Q&A. Again, your lecture was really fantastic and inspiring. Just a couple notes about the show. Our last raffle for the day is, I forgot what it was. It's Drusen. So you can go ahead and type Drusen in to get your raffle code. Please be sure to jump over to the expo right now. We have some great lectures going on. And then we have one more CE lecture in about an hour. Looking forward to it with everybody.
Thank you so much, everyone, for tuning in. Any questions, feel free to email me.